We are going to discuss about the decay, and this lecture is based on various guidelines. And this is what I'm going to do: a little bit about physiology, and then discuss about the BSPD guidelines, and at the end, 2 case discussions. The killer in decay and its management is cellular decay. That you have to understand, because we are doing everything possible. One thing is to prevent cell by edema. The second thing is to treat possible cell by edema. The main aim of the management is treat acidosis and prevent cell by edema. That's you have to understand very clearly, because what happens is various people think that the decay management is based on the treating hyperglycemia. It is not. So in fact, in decay, hyperglycemia is a protective thing. So we need hyperglycemia to maintain. You don't have to reduce sugar when you are managing decay. You will understand in a minute. So if you think about the summary, so this is what you should know. When you're managing decay, if you're not doing these things, they will go home. So no insulin boluses, no stopping of insulin infusions until normal anemia, no fluid boluses unless you see vascular decompensation, no rapid rehydration, always correct over 48 to 72 hours, no rapid correction of hyperglycemia, no hypotonic fluid, always use normal saline, 0.9% normal saline, and no bicarbonate, because all these things can cause cell by edema and kill the child. So basically, if you are not doing these things, they will survive. And pathophysiology, I'm not going to go into detail. So basically, it is lack of or decrease in insulin. Because of lack of insulin, the counter-regulatory hormones are more, and this leads to increased glucose production by liver, causes hyperglycemia, and the same thing will lead to increased lipolysis, so that you will have ketonemia and metabolic acidosis, and hyperglycemia and acidosis results in osmotic diuresis and causes dehydration and loss of electrolytes. So if you think about the clinical features or the salient point in decay, these are evident. So hyperglycemia, ketonemia, metabolic acidosis, dehydration, loss of electrolytes. So those are the main problems in decay. So when you're coming to diagnosis, that is also very important, because we are getting so many calls saying that the child's that we are managing a child's sugar is more than 400. So we have started insulin like diabetic ketoacidosis and so on. So you should diagnose decay. So there are 3 things in decay. It should be diabetes, there should be ketonemia, there should be acidosis, DKA. So diabetes means sugar should be more than 11 millivolts or more than 200 milligrams per deciliter. And then ketonemia should be there. This is not ketonuria. And pH should be low. So venous pH below 7.3. We think it's acidosis. And going by the bicarbonate, it should be less than 15. So 3 things are there. It should there to diagnose decay. Diabetes, keto, acidosis. So again, the severity of diabetes is based on the pH. So that itself shows that it is not hyperglycemic. So otherwise, we can categorize according to hyperglycemia. So it is not. So we call it mild decay, 7.2 to 7.3. Moderate decay, 7.1 to 7.2. Severe decay, 7.1 below 7.1. So yes, that shows the main issue is acidosis. Then aim of the management, basically what we are doing is we provide insulin to switch off ketogenesis. That also you should understand. We are giving insulin not to reduce sugar. We want to switch off ketogenesis. Less insulin, what do we produce? The body. So if you want to stop ketogenesis, we should use insulin and correct electrolyte and glucose abnormalities and replace fluid deficit slowly over 48 to 72 hours. So these are our aims. So giving insulin to switch off ketogenesis and correct electrolyte and glucose abnormality and replace the fluid deficit slowly over 48 to 72 hours. And it is not just correction of hyperglycemia, that you have to understand. Before thinking about the management of decay, this concept is very important: effective osmolarity. So effective osmolarity is 2 times sodium plus glucose. So if you think about this normal condition, so this was taken from the this article, Dr. Desmond Bourne is a world authority about PKA. So what it says, this is my intracellular fluid, this is extracellular fluid. I'm taking intracellular fluid as the drain. So initially, you are having osmolarity same on both sides. So extracellular fluid is 280, intracellular fluid is 280. Main ion in ECF is sodium, main ion in ICF is potassium. So that's the difference. But anyway, both are same. Then all of a sudden you are adding some glucose to the extracellular compartment. This is what happens in decay. So I have added 40 millimoles per liter. So now the osmolarity has gone to 320. So there is 280 plus 40, 320. So what happens with time? Now higher osmolarity on the extracellular compartment, lower osmolarity in the intracellular compartment. We will shift from intracellular to extracellular compartment. So with time, the extracellular osmolarity will go down because fluid is coming from this side. Intracellular osmolarity will go up because fluid is shifting from intracellular to extracellular. So with time, it comes to another equilibrium that the osmolarity should be between 320 and 280. That you have to understand. Because fluid is shifting from here to here, the 280 is going up, 320 is going down. It will be somewhere, so there will be another equilibrium with a higher than 280 osmolarity. So this is what the same thing that I'm discussing. So when you are starting treatment, our body or our cells are having higher osmolarity. Basically, what I'm trying to say is decay is a hyperosmolar condition. So we are having a higher osmolarity in decay, right? So decay is a hyperosmolar condition. So I'm taking the osmolarity as 320 just for the explanation. So sodium is 280, glucose is 40, 2 times sodium plus glucose is 320. This is how this 320 happens. So intracellular fluid also we have 320. Right. This is our carton. Then if suddenly if you drop extracellular osmolarity, so 320 to 200, what will happen? We will shift from ECF to ICF because cell breaking. So if you can understand this, you know everything about decay. So management is very simple. So if you are using hyponatremic solutions like N/2 or N/5, same thing will happen. The hyponatremic solution, N/2 means sodium is 77. So osmolarity is 144. So basically you are dropping the extracellular osmolarity. So fluid will shift from extracellular to intracellular compartment, causing cell mediator. Now I think we are using normal saline. So we think that we have 1 liter of fluid in the extracellular compartment. I'm going to add 1 liter of normal saline. So normal saline contains 154 millimoles of sodium. So I can do the calculation. Now this volume become 2 liters because I'm adding 1 liter from outside. So I have done the calculation. So basically osmolarity has become 340. Initially it's 320, now it is 340. What I'm trying to say is even normal saline is hyponatremic in decay. So even if you're using normal saline, you're dropping your osmolarity. So even normal saline is hypotonic in decay. So if you're using huge amount of normal saline, so what will happen? Now instead of 1 liter, if you're using 9 liters, now the total volume becomes 10 liters. Osmolarity drop to 380. So if you're using more normal saline, osmolarity can drop further. That is the rationale of not using huge amount of fluid in all the guidelines. Whatever the guidelines that we are using, all the guidelines are saying restrict fluid. So various places they are trying to restrict fluid, but the rationale is this. So normal saline, we are usually using normal saline. So normal saline is hyponatremic compared to the osmolarity in the decay. So don't use huge amount of normal saline. So large volume of normal saline, you're dropping excessive osmolarity, shifting fluid from excessive to intercellular compartment, cell edema, you can easily kill the child. So don't use large volume of normal saline unnecessarily. Bolus of insulin, same thing will happen. Now, initially glucose is 4. So if I am using the bolus of insulin, if the glucose become 4, now the osmolarity is 284. So you are dropping excessive osmolarity. It will shift from excessive to intercellular compartment, cell edema, and child. Even without the insulin bolus, if you give insulin infusion, there's a rapid drop of sugar. The same thing will happen. What about the bicarbonate therapy? So then, this is again very important to understand. So when we are giving bicarbonate, what will happen is you have a chance. We are giving bicarbonate. This Henderson-Hasselbalch equation will shift from left to right. You are producing carbon dioxide. So this carbon dioxide is very freely movable ion. You can cross the blood-brain barrier and go to the brain. There, carbon dioxide will connect with H2O, and the same Henderson-Hasselbalch equation will shift from right to left. So basically, you are producing a chance. So outside the cell, this goes this way. Inside the cell, this goes this way. So you can cause intracellular acidosis. That is one thing. The second thing is carbon dioxide is the cerebral vasodilator. So when the carbon dioxide is entering into the brain, you can have vasodilatation in the brain and hyperemia. So two things. One thing is intracellular acidosis. Second thing is cerebral edema. So there's no place for bicarbonate in the management of DK. So what they say in the American Diabetic Association guidelines, the arterial pH should be less than 6.9 1 hour after rehydration if there is a circuit compromise as a result of acidosis. I'm always in this lecture, I'm always telling that it's like a anagasdava, BSC. There are three things very rarely occurring. So basically what they're saying is don't do it. Right? So you want to give the bicarbonate, arterial pH should be less than 6.9 after 1 hour of rehydration. So that's very rare. And if there is a circulatory compromise as a result of acidosis. So, yeah, rare. So basically what they say not to do. And then this concept was very important when we were discussing DKA for the anion gap. So anion gap is the summation of the anions into cations. So usually it should be same. So there shouldn't be anion gap. There should be positive ion and negative ions. They are in equal amount in our body. If there's an anion gap, it is due to unmeasured anions. Some of the anions we are not measuring. So basically we are measuring sodium, potassium, chloride and bicarbonate. We are measuring these two and these two, not the other things. So if you are not, if there's a gap, it should be due to unmeasured anion. Unmeasured anion. So high anion gap means unmeasured anions. In DKA, it is due to ketone. So ketone bodies we are not measuring. So the anion gap is due to ketonemia in DKA. So ideally, we should monitor the anion gap during the therapy. So if the anion gap is normalizing, that means our treatment is effective. Because it's very difficult to do ketonemia, blood ketone levels, even in the developed countries, it's very difficult to get a blood ketone level. So what they're doing is they monitor the anion gap. So if you can monitor the anion gap, if the anion gap is normalizing, that means the treatment is effective. So insulin must continue intravenously until anion gap has normalized. Right. So then the second concept is metabolic acidosis. This is how the pediatric intensive is looking at the acidosis. So acidosis, metabolic acidosis is low bicarbonate concentration. It's not a chain. So we are looking at the bicarbonate. So there are only three ways that you can have low bicarbonate concentration. One thing is loss, second thing is titration, third thing is dilution. So loss is very simple. The bicarbonate can be loose, bicarbonate, vomiting, diarrhea, renal loss. So if there is loss in bicarbonate, treatment is replacement. So that is why in renal tubular acidosis, bicarbonate is losing. So the treatment of renal tubular acidosis, you have to give bicarbonate. There's no question about it. Then second thing is titration. So we have seen this. So when you are producing a chance, this heterocyclic equation is shift from left to right. So chain production combined with bicarbonate, H2CO3, CO2 and H2. So basically it's shifting from left to right. So bicarbonate concentration goes down. So this bicarbonate concentration goes down because of the chain production. So that is called titration. Here, the treatment is not giving bicarbonate. If you give bicarbonate, what will happen? This will further deteriorate. Chain is anyway producing, you are giving bicarbonate. So shifting this way, producing carbon dioxide, going into the cellular circulation, it's a cellular vasodilator, you can kill the child. And carbon dioxide is freely movable, so it goes into the cell and causing intracellular acidosis. So you should not do that. It's like, so please don't do that. So the treatment for this acidosis is treat acid production. So there's no place for bicarbonate replacement in DKA. There's no place for bicarbonate production, bicarbonate treatment in dengue. There's no place for bicarbonate replacement in lactic acidosis because the treatment is treat the cause, treat the acid production. And the third is dilution. So take this. So we have 1 liter of solution and 10 millimoles of bicarbonate. So my concentration is 10 millimoles per liter. So I'm going to add another 1 liter of normal saline. So now my volume is 2 liters. I have same 10 millimoles of bicarbonate in the solution, but the concentration is 5 millimoles per liter. So theoretically, I have produced acidosis. I have reduced the bicarbonate concentration by adding normal saline. That is why some people say normal saline is acidic. So there's no acid in the normal saline, but since its dilution causes this, it is acidic. So treatment for this is possible restrict the fluid, but if the clinically it's not a problem, just forget about it. How can you detect it? So do a chlorine level. So we are usually using normal saline, that is HCl. So if you're having a high chloride level, that is hyperchloremic metabolic acidosis, basically it's due to dilution. So you don't need a proper treatment for this. So that is very important. Why we are learning this in diabetic ketoacidosis? On presentation, they have acidosis is due to acid production. So keto acid production. So it's due to titration. The second one that we have discussed. So this will improve with insulin and fluid. So diabetic ketoacidosis. Acidosis is due to the keto acid production. So when we are giving insulin, you are treating that, and we are giving fluid. Again, the lactic acidosis part. We are having low perfusion. That's a part of acidosis due to lactic acid, lactate production. So this will improve with insulin and fluid. But later, they can have metabolic acidosis. This is due to dilution because we are using normal saline in the treatment, or the guidelines say we are using normal saline. So when you are giving normal saline, since bicarbonate is getting diluted, you will have acidosis. This is due to dilution. So it's a hyperchloremic, non-anion gap acidosis. So if the anion gap is normalizing, no clinical concern. So this is again very important. We are getting so many calls saying that we are managing this child with diabetic ketoacidosis. The child is clinically improving, but the acidosis is not improving. So you don't have to worry. So the acidosis is not improving. There is a reason for that. If you are really worried, do a chloride level. So that shows that it's a hyperchloremic metabolic acidosis, and you can calculate the anion gap. If the anion gap is normalizing, anion gap is coming down, you don't have to worry. Right. That's all about DK. So take home messages. Please say no to hypertonic fluid boluses, rapid rehydration, insulin boluses, rapid correction of hypoglycemia, bicarbonate. So if you are not doing these things, child can go home. If you are doing this, can cause lipedema, easily you can kill the child. So little bit about management. So first thing is you have to diagnose the DK. As I mentioned, it should be DKA, diabetes ketoacidosis. Then your management is depend on whether you are having vascular decompensation or not. So if you are having a shock, discussed about shock previously. So if you're having shock, forget about decay and treat shock. So that's a different thing. But having said that, this is one condition that we are using 10 ml per kilo as fluid in shock. So four conditions: decay, dengue, neonate, and trauma. These four cases we are using 10 ml per kilo as fluid. Various reasons, but anyway, that's the important thing. So resuscitation is ABC, normal saline 10 ml per kg. So that's the management. So after that, we think about if there's no vascular decompensation, so you are starting with normal saline and go ahead. So these, let me forget about this one because now we are using different guidelines. Whatever it is, then if there's no shock, you have to calculate the dehydration, percentage of dehydration. So now, earlier, before 2005, the guideline says, 2010 guideline says you can take maximum of 10% dehydration. And now it's over. Now we can use even 10% dehydration. So whatever it is, you have to calculate the fluid deficit or the dehydration and give that fluid deficit over 48 hours, 48 to 72 hours. Usually in WHO, in the APLS method, what we're doing is dehydration correction. You are giving the corrected amount. That means the percentage of dehydration, calculate the amount of fluid that you should give and give that fluid amount over 24 hours. That's the usual pattern. If the deficit is 500 ml, you are giving 500 ml in addition to the normal maintenance over 24 hours. So here we are giving over 48 hours. Sometimes we are delaying it up to 72 hours. That's the difference. So after 1 hour, you are starting insulin. So insulin always 0.1 units per kg power. There's no halfway. And please don't use insulin boluses. So before starting insulin, you have to think about this also. If the child has passed urine, if the potassium is less than 5.5, with insulin, you are starting potassium also because you know. So we are using insulin. Already dextrose is there in the body. So it's like giving insulin dextrose. The potassium will shift from extracellular to intracellular compartment. So it will drop your potassium level in extracellular compartment. To prevent that, you are giving potassium, respective of the total body potassium level. So if the potassium is less than 5.5 and the child has passed urine, you have to use 40 millimoles per liter of insulin. That's the concentration. So basically, we are adding 20 millimoles to each pint. So aim is to keep potassium between 4 and 5. After 3 to 4 hours, if the acidosis is improving, and if the RBS is below 15 or if the RBS falls more than 5 millimoles per liter per hour, you're changing IV fluid to normal saline with 5% dextrose. If the RBS falls below 10 millimoles per hour, you're changing normal saline to 10% dextrose. Because now again, people think this is to prevent hypoglycemia. No, this is to maintain osmolarity. Because I explained already, the osmolarity is 2 times glucose plus 2 times sodium plus glucose. So you have to increase sugar if you want to maintain osmolarity. So this is to maintain osmolarity. And I put it here. If the sugars are dropping further, you can decrease the insulin infusion to 0.05 units per kg power. So, I'm not very happy about this, but you have to do it because the aim is to use some insulin to switch off ketoacidosis. At the same time, keep the sugar in a higher level, so you can maintain the osmolarity. This is basically we are trying to maintain osmolarity. So if the acidosis is not improving, check insulin delivery system, consider sepsis. So improvement means clinically well, tolerating oral fluid, pH is more than 7.3, bicarbonate is more than 18. So you can start subcutaneous insulin, stop IV insulin half an hour to 1 hour after subcutaneous dose, determine the cause of decay. If there's any neurological deterioration during the treatment or even before that, headache, irritability, decreased level of consciousness, decreased heart rate, 2 differential diagnoses are there. This may be due to hypoglycemia or cerebral. So do a sugar. If the sugar is normal, treat for cerebral. These are the early and late signs of cerebral edema. I'm not going to go into detail. I'm not going to go into detail. And if there is cerebral edema, it's very important to use all the neuroprotective measures. So head elevation, midline position of head, minimum interventions, and the treatment is maintain or increase osmolarity of the extracellular fluid. So how can you do that? You can use mannitol, you can use 3% saline, you can use increase insulin infusion 0.01, 0.05. You can understand. If you increase the sugar, you can increase osmolarity. So to increase sugar, you can decrease insulin, or you can decrease the rate of fluid administration. Again, initially we discussed, even normal saline is hyponatremic in DK. So if you are giving more normal saline, you are dropping your osmolarity further. So if you are giving less normal saline, that means you are not reducing the osmolarity fast. So decrease rate of fluid administration. Observation and monitoring. RBS hourly. Aim of the sugar is decrease sugar less than 5 millimoles per liter per hour. Hourly input-output chart. Hourly neurological status. 2 to 4 hourly serum electrolytes and VPG, and follow effective osmolarity. Avoid a decrease of more than 2 to 3 millimoles per kg per water per hour. So mechanical ventilation. Usually we try not to ventilate. That is one condition that we try not to ventilate. The decay and asthma are the conditions that we try not to ventilate. If unavoidable, we should do this. On that, we'll discuss why we should not ventilate. So the carbon dioxide is very, very low in decay. Sometimes it's about 6 to 10. Right? Initially, we thought this is because hyperventilation. Hyperventilation causes low carbon dioxide. So people just keep quiet until 2005. There's a person called Robert Tasker. He was thinking about this differently. Because we know carbon dioxide is a cerebral vasodilate. So if you can control the carbon dioxide, if you can reduce the carbon dioxide, you can control the cerebral blood flow. So decay is a condition where you can have cerebral edema. So if I want to treat cerebral edema, I can control the cerebral blood flow. So he was arguing that low carbon dioxide is an adaptive mechanism. It's a physiological adaptation. So body is trying to keep cerebral blood flow in a minimum level by reducing carbon dioxide. That is why there is the hyperventilation. So decay, carbon dioxide is very low. So it's a physiological adaptation. But if you ventilate the child and if you try to normalize, now see the carbon dioxide is about 10. So what is our normal carbon dioxide? For us is 35 to 45. And after putting the tube in, what we try to do is to keep carbon dioxide in 35 to 45 level. So that is really, really high when compared to the physiological level. So easily you can cause cerebral edema and kill the child. So that is his argument. So how can you prevent that? What we are going to do is, if you want to ventilate, right, usually we try not to ventilate, but if you really want to ventilate due to some reason, maybe child is drowsy or whatever the reason, you try to ventilate. If you want to ventilate, do a blood gas beforehand and get the carbon dioxide. It may be 10, it may be 8, it may be 12. So try to get that carbon dioxide during ventilation. So your normal should be 10, normal should be 12 for that particular child. So that's the physiological need. So it's very, very difficult. So that's why we are trying not to ventilate these patients. So this is the article that I was telling you. Hyperventilation in severe diabetic ketoacidosis by Robert Tasker. This was published in 2005. So it's a landmark paper. After this, everything changed the management of diabetic ketoacidosis. Right. Now, two cases. This first case is from this Robert Tasker's the landmark paper. It's a 12-year-old girl. That was diabetic ketoacidosis, and they have done the update blood gas before treatment initiation. So pH is 6.79. Look at this. Carbon dioxide is 6. Bicarbonate is 1. So this is before 2005. They have given normal saline 20 ml per kilo over 20 minutes, and Rehydration was planned over 48 hours. Insulin was started at 0.1 minutes. And 4 hours later, child developed Cushing's reflex. Blood pressure high, arteries coming down, pupils are mid-size and reactive light, GCS is stopping, normal power tone reflexes, the carriage cerebral edema. They have started mentor and intubate. Because now, before 2005, whatever the cause, if there's cerebral edema, the treatment, one treatment modality is intubation and ventilation. So they have put intubate. So after 15 minutes, putting intubate, now the pH is 6.9, initially 6.79. Now the PCO2 is 32, initially PCO is 6 or 8. And bicarbonate is 4.8, initially it was 1. Basically, the blood gas is improved. But CT showed cerebral edema and cerebral tonsillar herniation. Both pupils are fixed and dilated. The patient died 2 days after heart attacks. So, this is the comparison. Arterial blood gas is improving. Carbon dioxide 6 to 32. So, physiology needs 6. But for us, normally is 35 to 45. Even this is low. So, we try to normalize, but causes cerebral tonsillar herniation. So, that's the reason for the death. Another case, this was managed by us in this 2011, and child 11-year-old presented with RA with fever, vomiting, irritability. LRGTU GCS was 14, they very shocked, weak pulse for periphery, sugar was more than 400, so normal saline bolus even 30 ml per kg. So after the fluid, bound impulse, blood pressure is already, but child disoriented, confused, drowsy, and GCS stop. Now, when you are listening to this, if you know the physiology, it's very easy to correlate these things now after giving fluid. So normal saline, so this osmolarity is low. So you are dropping your extracellular osmolarity. The fluid is shifting from extracellular to intracellular cerebral edema. That is why this clinical condition. So child was admitted to MICU because of drowsiness. So we thought our clinical problem is decay with cerebral edema. So we are deviating from the normal guidelines. We decided not to ventilate and try to maintain extracellular fluid osmolarity from the beginning. We want to increase basically extracellular fluid osmolarity. So we decided to do minimum fluid. We can only 3 ml. Higher concentration of dextrose early. So rather than giving normal saline, we have started from the beginning 5% and later 10%. Now you can understand what I'm trying to do. I want to give more insulin, more sugar to increase the osmolarity. Regarded by various senior people saying that now this person is trying to treat DK with 5% dextrose, normal saline 5% dextrose, normal saline with 10% dextrose from the beginning, even without hypoglycemia. Right? But we were using minimum insulin rather than giving 0.1, we have started 0.04. We were using 3% saline and vinegar. So what I want is to increase the osmolarity of the extracellular compartment. At the same time, give a little bit of insulin to switch off ketogenesis. That's my aim. So we are deviating from the guideline. So this is what happens to the child. Sugars of 400, 363, 53, 45, 300, 300, 228. So it's very high. So even over 4 days. So I'm very happy to keep this sugar in a high level because I know I'm keeping my osmolarity in the extracellular compartment in a high level. So I'm treating basically the CBD. So this is the risk rate. You can see initially mild irritable, drowsy, not responding to command, same drowsy, obey commands, so over 3 days, we have corrected everything except for the sugar. So sugar is protective in decay. So we're very happy if the sugar is a higher level. So decay, these are the take-home messages. Please don't use insulin boluses. No stopping of insulin infusion until normal anemia. No fluid boluses unless vascular decompensation. No rapid rehydration. It should be always over 48 to 72 hours. No rapid correction of hyperglycemia. No hypotonic fluid. Always normal saline. No bicarbonate because all these things can cause cerebral edema and kill the child. So, go to the next lecture. So before that, see what are the questions that you have.